So today, I'm super excited to welcome our guest, who's Professor and Division Chief, Pediatric Critical Care Medicine, Executive Vice Chair, Pediatrics, a physician leader in clinical education, Dr. Steve Schexnayder. Welcome to the Doc Talk.
Thank you. Good to be here.
So you've been a role model for professional development through teaching and clinical care. So in an academic institution such as ours, so what are the main professional development tracks from your perspective, any major differences between them?
Well, I think that's changed over my career. Initially, early on, there was the traditional, of course, researcher track where somebody generally didn't have a technical degree like an MD, was a PhD pursuing a research career. There was a clinician scientist and still a huge need for that. In fact, the numbers are quite low nationally, but someone who devotes probably at least 50% of their time to research.
Right.
And that can go a couple of different ways. That can be basic research in a lab, or even more often today can be applied clinical research
Right.
with clinical trials and things like that. At our institution, the bulk of our faculty are in clinical educator or clinical attending roles, where the majority of the activity is related to their clinical work, with the clinical educator having some focus on education and some expectations related to education. When I said that had evolved, I think really as I look to the next decade in academics, I think many promotions will be based on quality improvement
Right.
and work. And so you see, some people would call that a QI scholar or whatever. It's not a separate track, and most of the time in our own institution, it's part of a clinical educator track, but it's really a specific focus rather than education per se being the focus of quality improvement and really digging into performance science.
So I mean, obviously, in me being here in the last maybe 12, 13 years or so, I mean, I've certainly seen quality improvement being one of those new focuses of clinical care, just because it impacts outcomes. You have also had a leading role in developing revised pediatric cardiopulmonary resuscitation guidelines that we all use, once we have a patient who's deteriorating, and these are the guidelines from American Heart Association. So how could physicians on, let's say, clinical educator track, which is the bulk of the folks here, how could we get involved within professional organizations at, for example, national levels? And in the back of everybody's mind is it really worth the time and effort, especially when there is so much else to do?
Yeah, and I think that has to become, really the second question becomes an individual answer for the individual physician and faculty member. From my own journey, I'm a big believer in the way you engage in things like that is through sweat equity.
Right.
I taught those courses here early in my career with regularity. I became involved at the state level. That led to the state sending me to a national meeting, me simply going up and asking the question about a particular focus of the program of the Pediatric Advanced Life Support, or PALS program, led to me being invited to write that portion.
Right, yes. Yes.
And then ultimately being asked to lead the pediatric group nationally. And then for most of the last 15 years, continued to be engaged, sometimes as a paid consultant toward the development of educational materials. Now I'm back into a volunteer role on the International Liaison Committee on Resuscitation, where there are 17 of us from around the world who work on review of the resuscitation science, and then make recommendations to the different what are called councils, the groups like American Heart Association that write guidelines. American Heart Association is a little bit of a misnomer because their guidelines are actually used by the majority of the developed world and
Right,
used
right.
in about 180 countries. But that's been a unique opportunity, and been a tremendous blessing. I've traveled the world. I've traveled the U.S. and spent a bit of time in South Africa last year working on the guidelines and have contacts from around the globe.
That's amazing.
But I think at the end of the day, it's you being willing to stick your neck out and say, hey, I'm interested. And then not just say you're interested, but then you actually deliver on what you commit to. I advise young faculty members, if you're at a professional meeting, go to a business meeting. Professional societies are always looking for volunteers. And a lot of people volunteer, but not a lot of people volunteer and then deliver. And those people that consistently do that, more often than not, move into leadership positions.
So, so that sort of leads me to the next question. So you were talking about earlier about quality in clinical care and quality in education. So quality in education, particularly in clinical education, especially after the med school. So in your view, what are some of the resources that are available to us as faculty at our institution that we can use to develop innovative educational products that are high tech, that could be cutting edge, and obviously that could be useful in the present day and age?
Well, I think part of that, we've benefited from technology and the world is shrinking. I did the Teaching Scholars program at UAMS.
Yes, I remember that.
Which is now over 20 years old.
Yes.
And I believe I was in the second class of Teaching Scholars. And my project was about really teaching residents how to be better educators since they spend so much time with our medical students.
Right.
And that was my intro. That kind of still works for some people. There are a lot more in terms of online opportunities. There are professional development courses. And then there are really a number of institutions now that, for those that are really want to be engaged in medical education, that can get masters in medical education.
Right, there is one. Yeah.
Probably the best known program in the country is from Cincinnati, and we have past graduates on our faculty of that master's program. We have one currently enrolled as well right now. We may have more than that. I'm just aware of one. So I think there are a number of opportunities, but I would. First and foremost, you set a goal. That goal may be something small. It may be really to develop myself as a bedside teacher. It may be to develop a module. But in most cases, once you start that locally, there becomes an opportunity to present that work at least regionally, if not nationally. And once people see that becomes another opportunity for you.
Yeah, that gets recognized on a national level. So moving on, I want to talk about something which I find particularly inspiring about you, your medical missions. So, the other day when I was reading, what I found was, according to WHO, there are 2 billion, B as in B, billion people, which is almost a quarter of the world population, does not have access to any medical care whatsoever. And I know you've been very actively involved in medical missions to South America and to some other developing countries. I really find it very inspiring, and your dedication to volunteer, your willingness to come out of our usual quote and unquote comfort zone and to give back to the underserved community. So in your opinion, why is it important for us clinicians to be involved in medical missions? What's been your driving force to do this over and over again?
Well, probably first and foremost, although I started when my children were young, I really had a desire for my own children to see that the way we live in West Little Rock is not the way most of the world lives. And poverty in U.S. standards is very different from poverty in world standards.
So true.
So it was really a desire as a parent for my kids to know that not just the privilege they have, but the responsibility that comes with that privilege.
So true.
And so for most of the last 25 years, I've skipped a couple of years this year because of COVID, led faith-based trips from our church, and we do medical, dental, optical care in Central America, and we on a longer term, the ministry I'm involved with actually takes guardianship of kids in Honduras and in the equivalent of DHS custody and commits to raising them. And so we have a couple of pictures on our refrigerator of kids that we financially contribute to their education and healthcare and feeding every month. And
That is awesome.
that's just been a fun personal journey for us as a family. That and to really get at your answer, I think from a personal standpoint, it comes down to my faith. From the scripture, to whom much is given, much is required.
Right.
And it's no matter your faith background, I think those of privilege have a responsibility.
So true. Yeah, I mean, I personally have never been on a medical mission, but my wife has to a couple to the refugee camps. And, when she came back last time, I mean, she definitely was a very changed person in terms of appreciating what we have, which is a great sort of education for our kids as well, just like what you said earlier. So, obviously all of these activities, clinical care, education, the spirit of volunteer, and to give back to the community. I mean, all of these collectively, or even on an individual level, they've got some impact on institutional culture, which essentially molds the perception, and it helps to develop our brand or define our culture. So purely from philosophical standpoint, not strategic, but purely from philosophical standpoint, why do you think it is imperative that an institution should pay a close attention to its culture to make sure that it represents our core values?
Well, I think fundamentally it's a matter of integrity. The words on a page are meaningless unless they're lived out.
So true.
And quite frankly, if they're simply on a page, but they're lived, the organizational culture lives in a different way, it's hypocritical. And I think people see through that very quickly. And
Absolutely.
And culture is hard to change. It's a challenging, dot to move along the page, and but it can be done. But it really comes down to one individual decision at a time, and really the daily choices we make that ultimately end up collectively impacting our culture.
Steve, so both in an official manner and also in an unofficial manner, you've been a mentor to me. And I remember last year in one of our meetings, you talked about communication and team building, something that you are very passionate about. And you gave me a book. I still have it. I mean, the title was The 5 Dysfunctions of a Team. It's a small book, again, a bestseller, which was a great read. And I particularly found great wisdom in how the author very brilliantly talks about strategies to overcome the top 5 quote-unquote dysfunctions which can destroy a team, namely absence of trust, holding of grudges, fear of conflict, lack of transparency, absence of commitment for honest accountability. So right now, any favorite books recently that you would have read or you would like our listeners to consider reading?
Well, I would say 2. One, a little more contemporary than the other, but like The 5 Dysfunctions of a Team, I'm the author, Patrick Lencioni, is probably my favorite all-time
He's great. He's
business
absolutely
writer.
wonderful. Wonderful.
His latest work is The Ideal Team Player, and it really talks about building a team, and he describes 3 things you want in that ideal team player.
Right.
And none of us are a perfect compilation of that, but the 3 characteristics he says are so important are hungry, humble, and smart. Hungry meaning you are willing to work hard. Humble, pretty self-explanatory, but for those that want a definition, I think C.S. Lewis's definition of not thinking less of yourself, but thinking about yourself less is a good one, so that you make others a priority in your word and deed. And then smart, and he's really not getting at IQ here, but he's really getting at EQ, emotional quotient, and people's ability, which can be developed to become better emotionally smart and to read situations and to read people and to respond to those situations.
Right.
So I would say I have to talk about Lencioni anytime I talk about a personal development favorite. But the book I've been reading or listening to actually right now is more related to what's happening in our society, and that's a book on unconscious bias.
Yes.
And the title is simply Biased, as we've gone through some of the demonstrations and protests, and it's made me realize that I have those, and I have to think about them. We all have them, and we all need to think about them. And so this social psychologist from Stanford basically walks through her journey in that, as well as her work, and it's written from something that's very intriguing to a physician, the neurophysiology of some of those aspects of bias. So for me, that we've been on a journey as a family in understanding we need to think about this differently.
Right. I think I may have heard about this in NPR recently, and I've not heard the podcast, or neither have I read the book. But I mean, the commentary was amazing. So this is going to be at least on my list of books to read in the coming months, definitely. On a slightly different topic, so you've been on active clinical practice in critical care medicine, which is very demanding. I mean, we sometimes share patients, and I see that firsthand as well. It's also very stressful. I mean, these patients are sick, and obviously, critical care in general has a high burnout rate amongst all providers, clinicians included. And we know the effects of burnout are not just limited to individual, but it directly affects their colleagues, their patient care, their family, and most importantly, their own welfare. So from your experience of being very active in clinical practice, what's your advice to younger or middle career faculty? What are the top 3 things that they should or they could do to bring joy to work and beat the crap out of this burnout?
That's a challenge, and I think particularly in critical care it is. If you look at the statistics, critical care consistently ranks toward the top
in
burnout.
Yeah, exactly.
I'm about not quite 30 years into my career. If you count my critical care training, I am 30 years into my career. But I think the things are you have to find meaning in what you do. And sometimes in critical care that can be very hard because not all of our patients survive, but finding meaning can be helping a family through a very difficult, one of the, if not the most difficult hours of their life.
Right.
So finding meaning in what you do, finding joy in something you do every day, whether that's an interaction with a peer, interaction with a staff member, interaction with a child. At heart, we're pediatricians, and so we get to play games.
I'm sure, yeah.
And so I sometimes describe that as being paid tax silly at work. And so as a pediatrician, you get to do that. And then most importantly, I think, and probably the biggest challenge in my career is really maintaining balance. You're never going to do it perfectly. You're going to have seasons where perhaps you rob your family or your spouse. You're going to have seasons where you rob your work.
Right.
You're going to potentially have seasons where you rob your personal health. Right. But figuring out how, if you're in one of those seasons, to have someone close to you who will say, hey, I'm concerned about that is so important. And I think having true friends that can ask you hard questions and be willing to, be reflective and open and transparent with you is hugely important and probably one of the major factors for me. Most of the time, I think of my care has transitioned from the child to my care has transitioned to the family.
So true, yeah.
And those have been some of the most meaningful relationships of my career. In fact, I have families of children who've survived that I still occasionally hear from. Got a video from one the other day that I took care of about 6 months ago, who we had a very difficult conversation about how this might end. And then there are others who didn't survive their illness or injury, but had the opportunity to help families through some very challenging moments.
And those obviously relationships last a long time.
They do.
They are almost a lifelong relationships. So that's for sure.
They do.
So at the end, how could we not talk about COVID? I mean, we were talking about earlier before even the podcast. So even if we don't want to talk about COVID, so I mean, obviously COVID has changed the way we live our lives. So top 3 things that may have impacted you personally, and how have you dealt with those challenges?
We saw a lot more family time, because as most of us, when I wasn't seeing patients, I tried to do my work remotely. Right. I found I had actually learned this lesson before COVID, but it really gave me some different tools to utilize it. I found I can often actually be more productive working from home than I can from the office. That doesn't mean there are not times that you don't have to be here, but you can, with technology, accomplish a lot remotely. But there are challenges. I think the other thing is as I believe the governor said the other day, well, in our previous experience with this, of course, said in jest, we have no previous experience like this. It's a learning lab. We're going to make mistakes.
Sure.
But we're all realizing we have to do work a little differently.
Right.
And there are ways we can do that. I think one of the great benefits of it will be that physical presence in many circumstances can be it can be replaced utilizing technology.
So true, yeah.
Can't for everything, but follow-up visits in particular, I've personally had by video that can work pretty well.
Right.
There are a lot of lessons. I really think this will push our use of video technology because we've had to do it. We hopefully will not go back to where we were.
Hopefully not.
When that was all over, but hopefully build on the lessons. And really some of the federal barriers to doing that will dissolve because we figured out we can do things differently.
Steve, thank you so much for your time today. This podcast has been a joint team effort with the Children's Hospital Process Improvement and also strategic marketing. And together we're thankful to all our audience for listening. If you haven't already done so, please subscribe and you will find value in it. And if you've already subscribed, thank you. I believe this podcast is unique to highlight physician careers and as they share some of their valuable life lessons, which could connect us professionally and help us grow collectively. If you like it, please also share with colleagues and friends on social media in this age of social distancing. Until we meet again next time, stay well, stay safe.